I would like to introduce to you our doctor here, and that's Dr. Rohit Malhotra. Dr. Rohit Malhotra comes from University of Virginia, Charlottesville, United States. Dr. Malhotra is one of the leading electrophysiologists with a keen interest in ablations of atrial fibrillation, left atrial appendage closures, and as well as CRTs. So the questions that we are going to have to him will cover most aspects of electrophysiology. So welcome, Dr. Rohit.
Thank you very much for having me. It's been a pleasure.
So I'd like to start off with the latest guidelines that have just been published on pacing a couple of weeks ago. And they have expanded the utility of CRT implantation in patients who have a CHB with an ejection fraction between 36 and 50%, and where you expect repacing more than 40%. So I would like to know about your practices in the United States and how are you looking at it?
Yeah. So obviously that data is all based on the BLOCK-HF trial, which was published now about 3-4 years ago. That trial actually took quite a long time to enroll. The full number of patients actually never met the number that were expected to enroll. I think part of that ends up being that our institution, like many in the United States, including those that participated in BLOCK-HF, if we take a simple dual chamber pacemaker implant, that usually takes roughly an hour. If we put in a CRT device, that can take anywhere from 1 to 2 or 3 hours. And so I think that was part of the challenge of that. However, based upon the results of that trial, when we have patients who come to the hospital with complete heart block, our predisposition to putting in CRT-P devices now is much higher. One of the other things that has become more commonly used in the last year or so as well in the United States, there's been more His bundle-oriented pacing. Now, the challenge with that ends up being that we don't really have any true randomized trials to look at long-term outcomes. Our experience has been across the United States that lead placement may have higher thresholds in the His position, and those thresholds tend to rise over time. And so we don't know whether, in someone who has complete heart block, whether we're able to actually implant and pace in the His position.
True.
So if we plan for His position pacing and then have to change to a CRT-P, that can be cumbersome. Changes the plan for the day with the lab, or vice versa, saying we're going to proceed with CRT-P placement, but then there can be challenging CS anatomy. Or if the patient is, it takes longer to get a lead in and we're uncomfortable with how long they have heart block or how we're pacing them in the interim. So in each of these cases, I think we take it in a case-by-case basis. So for younger patients, we're more likely to implant either a CRT-P or a His bundle lead. For older patients, there are often other comorbidities that come with the complete heart block, and so that'll impact our approach and planning for the procedure.
Yeah, I think I would like to add about the BLOCK-HF and the BioPace trial. When you review the data, if I understand that correctly, BLOCK-HF gave very good results if you gave CRT, while BioPace said differently in patients with nearly preserved ejection fractions, and it said that probably you could go in for dual chamber. So I'd like to know from you, for a country like India where CRT would be available largely in metros, and would you consider telling us that maybe if you were to give a dual chamber for an ejection fraction of 40%, it's a good idea to go septal? Or do you think that you're still practicing apical? Would you like to talk about that?
So typically for us, at the Heart Rhythm Society meeting in the United States, I think every year there's a debate, a pro and con of septal versus apical pacing. And I think I've been to one of those sessions and had the one speaker say, if you are implanting in the apex, you are doing the wrong thing. So I typically actually still implant in the apex for a number of different reasons. One is lead dislodgements may be lower. In older patients, that's one of the considerations. So an older woman, I might consider placing more on a septal location rather than an apical implant. But our patients on the whole in the United States tend to be larger than they are in most of the rest of the world. We're winning in that regard.
Yeah.
And so I tend to worry a little bit less about perforation in those cases. And so far, the data for septal versus apical implant really has not demonstrated significant benefit.
True.
And so now the exception to that is likely to be His bundle pacing. The challenge with His bundle pacing is that there is a substantial learning curve both in terms of the implanting physician, but also post-implant management. For us personally in our institution, our post-device implant patients are usually seen by technicians, nurses post-implantation. And so there isn't really a clear way for us to delineate to our support staff that this is a His bundle lead.
True.
And then they need to look at it and understand, okay, how am I supposed to program this device? Am I supposed to program it with the lowest output for the longest longevity when in fact we implanted it knowing that it would have a higher threshold in order to capture the His bundle? And then in follow-up, how do we maintain that higher output in order to maintain capture in the His, particularly if there can be climbing thresholds over time? And so that experience, I think we still don't have enough of that experience and no clinical trial data to really support that. So if in fact we were to use the most supported data for complete heart block, really CRTP should be the approach that we take.
True.
That has the most data behind it.
So taking the question further, as far as His bundle, I think you have significant experience and excitement about the His bundle pacing. Would you recommend for the newer implanters, it's a good idea to attempt in sick sinus patients, or would you think that AV block, or do you think we should go ahead and give 2 leads, one in the RV apical and one in His bundle?
So I think generally if one is eager to learn how to do His bundle pacing, then the sick sinus patients are the ideal patients to learn on, because without needing to do full-time RV pacing,
right,
then at least we're putting in a lead into a position that may not have long-term consequences for the patient. If we, the steerable sheaths that we use to implant those very flimsy leads do allow for non-His position pacing. And so if we can't find an optimal His bundle position, we can still implant it safely in the RV. And so learning on patients who have fairly standard anatomy is probably the best way to start. That's not often how we start, but it probably is the best way to start, particularly if one is going to move in that direction.
So moving back to CRT and heart failure, I'd like to ask you, how do you do monitoring of your patients on their follow-ups?
Yeah.
Do you do remote monitoring, or what kind of policies do you all have?
So in general, at our institution, we follow the guidelines, which basically delineate 3 months. So post-implant, we see patients within 2 weeks. That's typically with a device nurse rather than with a physician necessarily. Following that, I usually will see patients at the 3-month post-implant mark. And then after that, they'll follow 3 months remotely and 6 months in office. So in a year, there'll be 2 in-office visits and 2 remote interrogations. In general, those data come to us directly into our medical record, and so we review that data. Typically, most of our heart failure patients are often followed by a heart failure physician as well, and if they're not, then we manage their heart failure therapies as well as examining volume status, which can be interpreted or indicated by device-based measurements, depending upon the device, either the St. Jude Abbott CoreView monitoring or the Medtronic Optival system. There are some nuances to those systems, though, in terms of knowing what they mean and whether they're important or not. I have certain patients who seem to have certain trends where we see that the Optival measurements will go up in a period of time without any accompanying heart failure symptoms. And we've actually looked back at certain patients, and in a year, we can see that every year they have a replicable pattern of Optival changes, which I can't explain, but we can actually see this pattern, often without accompanying heart failure symptoms, but often with as well. And so our device nurses, when they see a change in the Optival, will actually contact the patients and find out if they've had a weight gain or they have any symptoms of heart failure. And if they do that, they will note that and direct those patients to us. If not, then they note in their interrogation note to us, we've contacted the patient, they're asymptomatic at this time. The lead time between changes in thoracic impedance and heart failure symptoms can be disparate though. And so the patients are at least informed of the fact that there's been a change. Sometimes that leads to a change in their behavior and sometimes not.
So in your clinical practice, what is the percentage of patients that you monitor remotely as far as the heart failure devices are concerned?
So institutionally, between heart failure physicians and the electrophysiologists, I would say it's about 90%, 90 to 95% are monitored. The challenge across most institutions in the United States is actually trying to determine who's actually going to follow the data.
Right.
And so there are actually some there's some quirks to the billing associated with interrogation of these devices.
Absolutely.
And so whether we interrogate devices remotely for electrophysiologic parameters
Right.
versus heart failure parameters, those can actually build differently.
I see.
And they can be actually billed on a monthly basis. And so if one is looking for heart failure parameters, that can be billed more frequently, which can be challenging in a healthcare environment like in the United States, where there are challenges to costs.
True.
And I'd imagine more so here,
Absolutely.
where patients are going to be, I don't know if there are charges to remote interrogation or how that works domestically.
Yeah, so it's a bit complicated here. I would completely agree with you on that. And my question, which I think is very dear to implanting physicians who implant CRT, is to reduce the burden of non-responders.
Yeah.
So I want to hear from you, pre-implant to post-implant, what is your strategy to reduce the percentage of non-responders?
I think the most important thing with regards to non-response with CRT is to pick the right patients. And so truly following the guidelines. For patients with optimal guideline-directed therapy for 3 months with class 2 heart failure symptoms at least, if they have a left bundle and a QRS duration of greater than 150, those people I usually can say with some confidence, you're likely to have a good response to this therapy. For patients whose QRS duration still with a left bundle is between the 120 and 150, I usually will counsel those patients that you may not have as great a response. And particularly with right bundles, I say to them, this is really a decision that you would need to make, and we should make that together.
So if I can stop you here for continuation. In your practice, what is the percentage which would have a QRS more than 150 with LBBB versus the other?
Yeah, so the ideal patient for CRT implant is a diamond in the rough these days.
Absolutely.
They're very hard to find. Typically, most of our patients will end up falling in the 120 to 150 range. And those are difficult conversations to have. Typically, when we talk about CRT implant, we're hoping most patients they're interested in extending their lives, but most of what they want is an improvement in quality of life. And so to counsel people on how much benefit they'll derive from CRT therapy can be quite challenging. And those patients end up being the bulk of our patients. So we discuss
Pre-implant.
Pre-implant, yeah. So pre-implantation, we will discuss with the patient, look, this may not be the perfect EKG. You may have some response, you may not. And how to assess that response can be challenging as well. So I've had one patient who had several prior attempts at LV lead implantation, all of which failed, had recurrent heart failure hospitalizations and was referred for another attempt. So we were able to find a position, and when I saw that patient back post-implant, he said, I don't really feel better. But I said, you haven't been in the hospital in 3 years.
Right.
And so how do we temper that perception of what response is?
Right.
And so he actually had quite a successful response to LV pacing, but didn't perceive it that way. And so I think part of what we also need to do in speaking with patients is lead them to expect and what to expect. If we start off telling people you're going to, 3/4 of the time you're going to feel better, that isn't always, people expect, oh, I'm going to be able to get up and run around.
Yeah.
When in fact, that's not likely to be the case. We may improve somebody from one heart failure class 3 to 2, but we're certainly not going to take somebody from 3 to 1.
True.
So, and explaining that to patients, having them understand that, gain some insight prior to the implant, I think can be very, very helpful. Again, particularly here, where patients are going to be guided by, I have to pay for this device potentially, knowing which device might benefit them more and what they're seeking in terms of quality of life versus quantity of life can be potentially very helpful.
Right. So, in your post-implant, what is your practice in programming the device? Do you have the RV pacing on, or do you like to do it with pacing off? I'd like your inputs on that.
So typically, particularly with the current generation Medtronic devices, which will do adaptive pacing, in people who have a normal PR interval and a prolonged QRS, those devices can be very, very effective in avoiding RV pacing, which, as we know, can be deleterious to heart function and precipitate as much heart failure as not pacing, or as not BIV pacing. And so typically in those devices, I'm very happy to see how much LV only pacing they're having. Mm-hmm. We won't typically turn off RV pacing. We'll keep it on for the adaptive element of that. But in other device companies, we tend to have more fusion pacing, more RV and LV pacing combined. So I think there are some distinct advantages to that. Based upon the studies that we've seen, there does appear to be distinct benefit to avoiding RV pacing. But I don't typically turn off RV pacing. So in St. Jude devices or Abbott devices, they'll actually sense LV and sense RV. So one could program those devices, but they don't have the predictive nature that the adaptive CRT does to track the AV delay and appropriately pace so that there's fusion between intrinsic RV activation and then the LV fusion pacing. So that ends up being quite limited to just one device manufacturer, at least for us.
Another question which I'd like to ask you is, for the responder rate to increase, would you do an echo-guided optimization for every patient that you implant, or is it something which is reserved for the subset which does not respond?
So typically, we reserve echo optimization to non-responders. Mm-hmm. The data on echo optimization the challenge is just the dynamic nature of people, right? We're up and moving about. We do echo optimization while people are recumbent, and so it can be quite challenging, but that's usually reserved in our institution for people who will not respond. We are a research institution where we're doing pre-procedural MRIs in order to determine both optimal. It helps us determine both the venous anatomy pre-implantation as well as areas of scar and areas of delayed activation in order to determine what the best site of implant may be. So perhaps that leads to some better responder rates than perhaps otherwise, but in general we still reserve echo optimization to the non-responder.
Is there any role of, coming back to the HIS bundle, do you ever think there is a role of seeing the QRS duration when you do your pacing? Because what we've begun to do in our centers, a few of us, is supposing we're giving a dual chamber and we are giving a HIS bundle, would you like to consider that, let me see the QRS duration at various sites and then go ahead and do the pacing? Yeah,
so the data on that there really just isn't enough data to suggest that pacing in multiple sites is going to be helpful in terms of long-term outcome. The challenge ends up being that just in terms of doing echo optimization for CRT, you can also do QRS optimization for CRT.
Yes.
And there really isn't good data for one versus the other. And in the same way, there isn't necessarily good data for shorter QRS duration based on pacing.
Right.
So I think the one exception to that ends up being direct HIS-Purkinje pacing, right? So if we get into the conduction system when we pace, then that may have long-term benefit. But beyond that, having the QRS look more narrow doesn't mean that there's not going to be dyssynchrony.
True.
And so I think that ends up being one of the challenges. The other issue ends up being that just because the QRS is narrow doesn't mean that depolarization of the ventricle is done in a more synchronous fashion as though it was going through the His-Purkinje system. There's lots of evidence to suggest that fibrosis within the ventricle can lead to disparate conduction and dysynchrony. And so just because the QRS looks narrow doesn't mean that LV depolarization or RV depolarization is synchronous. And so I think that makes us feel better, but there's no evidence to suggest that there's long-term benefit to that.
In the post-Danish era, how has your practice changed?
The reality ends up being, I think, for most of us, we still are practicing in a pre-Danish area. For most of my patients, we talk about the advantages of CRTP versus CRTD. And so, particularly now, in about February of this year, the U.S. Medicare changed its guidelines and actually mandated that we have documented shared decision-making. Now, my practice had always been to do a degree of shared decision-making with my patients, talk about the risks of implant and post-implant management of the device and risks of complications. But now we talk a lot more about the benefits of CRTP versus CRTD and the time differential in terms of longevity between those two, on average in studies, being just months.
Right.
So.
I see. So, I think, would you like to speak on AF ablation a bit? We'll just touch one subject on one question.
Yeah, I think earlier in the CRT discussion that we had, there was a lot of, we talked specifically about AF ablation in the setting of heart failure. And I think, with the recent publication of Castle AF and how that impacts how we manage heart failure in the setting of atrial fibrillation, the challenges with AF ablation in an environment where we are doing a lot of it, the success rates are not always what we'd perceive them to be or what we'd hope they would be. And in particular, in patients with heart failure, those results can be poorer. And so I think we still have to approach those patients with, as long as they have an understanding that I'm going to get a procedure to manage heart failure and to help me symptomatically that may fail after some period of time, as long as they understand that and are have eyes wide open about that, I think that's a very reasonable approach. And I'll be seeing a 30-ish-year-old man with heart failure who's developing AF to talk about ablation I think on Tuesday when I get back to clinic.
I see.
And so patients are very aware of the fact that the outcomes of ablation are not always perfect. But when you take a young patient who develops AFib and an AFib-induced cardiomyopathy, for example, those patients would much prefer to manage AFib with an invasive approach rather than putting in a long-term device. And so I think a lot of that depends. So the patient I'll be seeing next week already has an implanted device. I'm thinking of another patient who is in his 50s, woke up one morning with severe heart failure, was hospitalized for 2 weeks, and cardioverted, maintained sinus rhythm, but then his AF was all a tachy-induced cardiomyopathy. And so he underwent ablation and has been doing quite well, but now anytime his heart rate doesn't feel quite right to him, he's quite anxious about the potential for recurrence, particularly of heart failure.
So I think my last question to you would be about left atrial appendage closure devices.
Yep.
So I want to understand that in your clinical practice, how often do you find a patient who you cannot offer an OAC and deserves to undergo a left atrial appendage closure?
So the challenges with that are actually quite deep. So just last week in the hospital, I was taking care of a patient that I'd done an appendage closure on 2 weeks prior. That patient had had a bilateral lung transplant, developed atrial fibrillation post-lung transplant, which one would think would be quite uncommon, but it happens a fair amount. We implanted the device knowing that she'd had prior bleeding episodes, and we discussed, you may bleed after we put this device in because we put people on anticoagulation.
Right.
And so I was seeing her in the hospital because she'd bled quite a bit, and we talked about what to do. She had upper examination, lower examination with no source identified, and she left the hospital on aspirin alone. So not ideal anticoagulation. But these patients are not a perfect population. We don't have good answers for them with regards to anticoagulation, because almost all of the patients that I'm implanting these devices in have bled already.
Yes.
And so I discussed with all of them, how are we going to approach anticoagulation post-implantation, and what do we do if there is recurrent bleeding? So they all understand that there are limitations. There is no perfect patient for this device. The studies all show that often patients have more issues with bleeding post-implantation than they may have beforehand until they get off of the anticoagulation. And managing that risk in the long term, determining how best to anticoagulate people, I think is going to be a big problem until we're doing. So ASAP-2 is a study that's being done to evaluate the safety of anticoagulation and what approach should be taken. So that's a very important trial, but it's very, very difficult to enroll patients in. The randomization is to either continued therapy with current anticoagulation, whatever strategy that may be, or device implantation. Most patients aren't willing to be randomized to no intervention. So they're not willing to enroll in that study. Right. So the companies had a very difficult time enrolling patients. But again, I think part of the way to manage that is to have patients understand what is going to happen to them afterwards and what the risks are. So as long as they understand that, as long as we have a therapeutic relationship, I think that it ends up being helpful to them.
So I'd like to thank you very much, Dr. Rohit, for being here with us, and look forward meeting you in the next upcoming CSIs in the coming years. Thank you very much.
Thank you very much. It's been a real pleasure.
You.